Magandang araw pong muli sa inyong lahat. My name is Jeffley Reboron, and this time we will be covering topics like Meconium Aspiration Syndrome, Hyperbilirubinemia, RH Incompatibility, and ABO Incompatibility for our subject, Nursing Care of the High-Risk Newborn to Maturity. Everyone, please bring out your handouts and your ball pens and pencils because we will have a fun-filled learning activity for today. Our first topic is Meconium Aspiration Syndrome, and I have already introduced this concept or this condition in our previous discussions. But this time we will be zeroing in on what it is, how it can be prevented, and how we manage it when we come in contact with these kinds of patients in our clinical duties. Now, you have to remember that meconium is present in the fetal bowel or in the digestive tract as early as 10 weeks gestation. That means that during the second to the third lunar month, meconium is already starting to form. Now, what happens is that when there is hypoxia in utero, or if there is low oxygen level going to the baby, this causes the reflex relaxation of the anal sphincter. And when the anal sphincter relaxes, it releases the meconium and it is mixed with the amniotic fluid. And that may lead to the formation of meconium liquor when there is a combination or mixing of both amniotic fluid and meconium. So what happens? This leads to meconium aspiration because the meconium liquor is swallowed by the fetus, and that may go to the lungs, which will cause now problematic conditions for the neonate. Now, you have to remember that for neonates who are born in breech presentation, they may pass meconium because of the presence of pressure to the buttocks during delivery. So there is a higher chance of these babies who are breech to pass meconium or to have meconium aspiration syndrome because pressure is being exerted in the buttocks during delivery. So that may stimulate the release of the meconium earlier. Also, when it comes to preterm neonates, they tend not to have meconium staining. Madalang lang po tayong nakakakita ng mga preterms who have meconium staining because the meconium has not yet reached the end of the intestines or hindi pa siya nakakababa doon sa descending colon. So basically, the meconium, since the fetus is still preterm, what happens is that the meconium is still in the ascending or the transverse colon and rarely na merong meconium na sa kanyang descending colon. Therefore, if a neonate is preterm, madalang lang po tayong nakakakita ng meconium aspiration syndrome. Now, what happens if the meconium enters the respiratory tract? Ang nangyayari po is that during the initial breathing, nagkakaroon po siya ng distress. Why? Because if the neonate inhales any fluid that is mixed with meconium, ang nangyayari is that there is inflammation in the lungs, which may also lead to problematic initiation of breathing. So yun po yung isang nagiging problema natin when there is meconium aspiration syndrome. So this is the reason why we monitor the FHT of the pregnant mothers. Every 15 minutes, nagmo-monitor po tayo ng FHT ng bata, because we want to determine if there is fetal hypoxia. Kasi alam po natin that if there is low oxygen level going to the baby because of less than 120 beats per minute na FHT or more than 160 beats per minute na FHT, that means fetal distress. And what the doctors will do is they will subject the patient to emergency cesarean section kasi nga it may lead to meconium aspiration syndrome in the end. So yun po yung pinipigilan natin. That's the reason why siguro nagtataka kayo bakit tayo nagmo-monitor ng FHT every 15 minutes. Yun po yung dahilan. We are preventing meconium aspiration syndrome kasi ayaw natin na mag-lead pa sa reflex relaxation yung kanyang anal sphincter, leading to the release of meconium into the amniotic fluid. Alright? Now, when we zero in on the pathophysiology of meconium aspiration syndrome, there are actually three mechanisms why respiratory distress occurs when there is meconium aspiration. Ang isa sa mga reason is that there is bronchial inflammation. Like I said a while ago, since the meconium is a foreign body to the bronchioles, ang nangyayari is that the body is forming a defense reaction towards this foreign body, leading to inflammation of the bronchioles. Aside from that, meconium aspiration can also lead to mechanical plugging. You always have to remember that in your meconium, there are solid particles. Okay? Ang mangyayari po is that these solid particles found in the meconium can block the small bronchioles and may lead to poor gas exchange. Kasi nga napoplug yung ating mga small bronchioles because of the formed or solid particles of the meconium, kaya hindi nakakapasok yung hangin inside, leading to poor gas exchange. Aside from that, the presence of meconium and basically inflammation will also lead to decreased surfactant production. Ang nangyayari po kasi is that there is lung cell trauma when there is inflammation, and that will lead to decreased lung perfusion, or there will be less oxygen going to the lungs because of the presence of the inflammation or the lung trauma. Ang nangyayari po, kung konti lang yung pumupunta na blood in the lungs of the neonate, is that it will lead to diminished surfactant production. So yun po yung lagi nyong tatandaan kung bakit tayo nagkakaroon ng respiratory distress in patients with in patients with meconium aspiration. Nagkakaroon ng bronchial inflammation because of the presence of meconium as a foreign body. There is also mechanical plugging due to the solid particles found in the meconium, which may block the bronchioles, and there is also decreased surfactant production because of lung cell trauma and edema. So those are the mechanisms why we have respiratory distress in meconium aspiration. Now, since the aspiration aspect often occurs inside the utero, hindi natin nakikita if the newborn was able to swallow the amniotic fluid that is meconium stained. However, meron tayong mga ginagamit na assessment findings for us to determine if the patient has meconium aspiration syndrome. Ang number one dyan is we look into the amniotic fluid appearance. And if the amniotic fluid appears greenish to blackish in color, then we consider that there is possible meconium aspiration syndrome. So as long as there is meconium stain, that already constitute to possible meconium aspiration. Aside from that, we also note the difficulty of these newborns initiating first breath. As mentioned earlier, these newborns who are meconium stained or who may have meconium aspiration syndrome may have difficulty initiating their first breath. So, pag yung mga patients natin na may meconium staining at nahihirapan na ding mag-initiate ng first breath or nahihirapan natin silang paiyakin, they may suffer from meconium aspiration syndrome. Isa pa na ginagamit natin na palatandaan for possible meconium aspiration syndrome is that these neonates may have very low Apgar score. So, alam nyo yung ginagawa natin, if you can still remember, yung mga assessments natin of taking the heart rate, the respiratory effort, muscle tonicity, color and reflexes. Kung naaalala nyo pa yun, yung Apgar scoring on the first minute of life and the 5th minute of life, magagamit ninyo yon when you are assessing for meconium aspiration syndrome. So, yung mga patients natin with possible meconium aspiration may have very low Apgar score and may be followed by tachypnea, retractions, or even cyanosis. Alright? So aside from that, these neonates may also have barrel chest appearance. So yung barrel ay yung usually chest ng mga neonates natin, it is wider on the transverse. And then when it comes to the anteroposterior diameter naman, it is smaller. So parang ganito yung shape ng kanilang mga chest. However, if the patient has Meconium Aspiration Syndrome, di ba nga nagkakaroon sila usually ng edema on the lungs, what happens is that nag-i-increase din yung anteroposterior diameter nila, therefore giving the appearance of the barrel chest. Okay? So like I said, the barrel chest appearance may be caused by the enlargement of the chest, which will lead to the AP diameter, increased AP diameter of the chest. So yun po yung mga gagamitin nating assessments for Meconium Aspiration Syndrome. Once you see those signs and symptoms in your neonates, you have to immediately act fast and provide therapeutic management so that we can alleviate some of the possible secondary effects of Meconium aspiration. So, yung unang gagawin natin is that we do suctioning. Okay? And what do we use? Typically, in the second picture, you can see the bulb aspirator being used to suction the mouth and the nose before the child even draws his or her first breath. So, ang ibig sabihin nito, bago pa natin paiyakin yung bata, we have to suction the mouth and the nose in the hope na baka yung mga meconium ay hindi pa niya nasaswallow lahat. So, tatanggalin natin yon before the child will start to cry so that the child will not aspirate it deeper. So, tanggalin na po natin yung mga meconium that are found in the mouth and the nose so that matanggal natin or makontihan lang natin yung papasok pa sa kanyang lungs once the child will start to cry. So, we use bulb aspirator immediately before we initiate the first breathing. But we will also need to do deep tracheal suctioning. So what the doctor will do is they will intubate the newborn and then they will suction the trachea and bronchioles to prevent meconium from entering the lungs. So, hindi po kasi abot ng bulb aspirator yung ating mga bronchioles and trachea. That's the reason why we have to do deep tracheal suctioning so that we can remove the meconium that have already been lodged on the lower respiratory tract of the patient. Aside from that, we can also give oxygen administration. Pero when you give oxygen administration to these neonates, make sure that the pressure that you are using is not very high or very strong. Why? Because there is a possibility that you might push the meconium deeper. So, instead of using nasal cannula, ang gagamitin natin when we give oxygen administration is that we use oxygen mask with low pressure. Okay? So, those are the things that we will do once we see patients have meconium aspiration or meconium staining. Ito po yung mga gagawin natin. Suctioning using the bulb aspirator and then doing deep tracheal suctioning and then giving oxygen in lower pressure. After doing those first three therapeutic management, the next thing that you're going to do is monitor the quality of respiration of the neonate. So, remember that tachypnea may be seen after we initiate first breathing or respiration. So, you have to monitor it so that the doctor will be guided of their decisions on the different therapeutic modalities that they will do or plan for the baby. So, very important po yung monitoring natin ng respiration. But you also have to remember that there will be fast breathing na makikita natin sa mga neonates. So, hindi po mayat-maya ay iniistorbo nyo yung doctor reporting that there is tachypnea. You have to remember that tachypnea may be typical for patients with Meconium Aspiration Syndrome. after initiating respiration. Ang importante lang na ginagawa natin is that we record the respiratory rate that we get, and then when the doctor visits, we show them the monitoring chart that we did. Aside from that, we also give or start antibiotic therapy for patients with meconium aspiration. Marahil nagtataka kayo, bakit kakailanganin ng pasyente natin ng antibiotics? Meconium naman is sterile. How can it cause infection? Now, hindi po yung rason na yon ang iniisip natin. That's why we give antibiotics for patients with meconium aspiration. You have to remember that after meconium aspiration, there is inflammation in the lungs. In the bronchioles, nagkakaroon tayo ng inflammation. Kasi nga, meconium is seen as a foreign object. What typically happens or occurs after inflammation is that there is infection that occurs. So, ang nangyayari is that there will be possible development of secondary pneumonia because of the presence of that inflammation that occurs as secondary nga sa meconium aspiration. So you have to ensure that you prepare yourself that you will be giving possibly gentamicin and ampicillin to these patients with meconium aspiration. So pag tinatanong natin kung, sir, pag magbibigay kami ng antibiotics, kailangan ba naming mag-skin test? Kasi yun yung ginagawa natin for adult patients. Well, basically, in my experience as a pediatric instructor, we don't do skin testing for neonates because they have not yet formed their immune response. So, hindi sila magkakaroon ng any reaction to these skin testing na ginagawa natin kasi nga immature pa lang yung kanilang mga immune response or immune system. So basically, ang ginagawa ng mga doctor is straight binibigay na yung antibiotics even without skin testing. But again, that may vary from one institution to another. So if you become nurses someday or healthcare providers, and if you are faced with that situation, it's always best to follow the protocol. But that's just a snippet of information that I would like to share with you na hindi po usually tayo nagbibigay ng skin testing for patients who are neonates pag magbibigay tayo ng antibiotics. Now, aside from giving antibiotics and monitoring respiration, we have to keep the child in a neutral environment. Ibig sabihin, as much as possible, we place them in environments with controlled temperature to prevent increased energy expenditure and diminished oxygen level. So, ginagawa natin to, like I said, time and again, that we are preventing acidosis. Kasi the more that the child is exposed to cold environment, nag-chills yung pasyente, mas maraming energy ang nasasayang or nagagamit. Therefore, the body will need more oxygen. You have to remember na ang problema natin in meconium aspiration is respiratory distress and possible hypoxia. So, magagawa natin to prevent acidosis by placing the child in a neutral environment. For example, in a radiant warmer, keeping the baby dry, doing kangaroo care or skin-to-skin contact. Yun po yung mga pwede nating gawin for patients with meconium aspiration. Aside from that, we can also do postural drainage with back tapping or vibration. Now, we want to position the child's head lower than the rest of the body to allow for the gravity to pull the meconium or possible secretions down and out of the mouth of the neonate. So, ang gagawin natin in postural drainage is that we loosen the mucus in the airway so that it may be coughed out or excreted by the baby. Now, what we do is nagtatap tayo, okay, in the different lung fields, in areas with the patient in different positions. So, pwedeng itatap natin yung kanyang side or itatap din natin yung kanyang back to allow the loosening of the meconium that may possibly be lodged on the bronchioles. Itatap natin siya para malaglag and then gravity will pull the secretions out of the neonate. So, yun po yung mga therapeutic managements na gagamitin natin in patients with Meconium Aspiration syndrome. Now, another condition that we will be discussing is hyperbilirubinemia, or the increase in bilirubin levels in the blood of the neonate. Now, you have to remember na yung hyperbilirubinemia natin usually is due to hemolysis or the destruction of RBC. And this hemolysis can happen in normal or physiologic processes or abnormal or pathologic processes. So, napag-aralan natin last time that there is normal hemolysis that happens on the 3rd to the 5th day of life of the neonate after delivery. So, namamatay kasi yung mga RBC ng mga neonate during the 3rd to the 5th day of life. So, yun yung tinatawag natin na normal or physiologic jaundice. However, there are instances wherein nagkakaroon tayo ng increased bilirubin level because of abnormal conditions. And isa sa mga conditions na ito is the blood incompatibility. And when we speak of blood incompatibility, there are two types. There is the ABO incompatibility and there is also the RH incompatibility. So we will be zeroing in on these blood incompatibilities in our next slide. Aside from those blood incompatibility na nagkukos ng hyperbilirubinemia, we also have possible conditions like liver, gallbladder, or spleen problems that may cause jaundice in our neonates. But like I said, we will be focusing more on the RH incompatibility and ABO incompatibility. Now, there are educational videos that are available online discussing how the RH incompatibility occurs in the neonates. So I will be playing a YouTube video, and if you want to watch it for yourself, you can also take a screenshot of the link that I will be providing, and then I will also be attaching the said video in our discussion so that we can better understand how RH incompatibility happens.
In this video I'm going to go through rhesus incompatibility because it's a bit of a tricky subject to get your head around, but once you get your head around it, it's really quite simple. So to start with, it's important to realize that the mum and the baby have quite different blood types. The baby has its own unique blood type because it inherits half of its genetic makeup from its father. The mum and the baby's blood don't actually mix, but they come in very close contact with each other across the placental membrane. When somebody talks about their blood group, they might say they're A positive or B positive or O negative. The first letter is their blood type, and the second character, the positive or negative, is their rhesus status. And if somebody's rhesus positive, it means that their red blood cells have the rhesus antigen on them. If somebody's rhesus negative, let's say O negative, it means that their red blood cells don't have that rhesus antigen on them. So why is this important in pregnancy? It's important because of one scenario, and that's where the mum is rhesus negative and the baby is rhesus positive. To understand why this is important, we need to look at what happens when you have the rhesus antigen. If you have the rhesus antigen on your red blood cells, your body learns to recognize that antigen as being part of your body, so it doesn't attack it. But when you don't have the rhesus antigen on your red blood cells, and you come in contact with that antigen, your body thinks that that is a pathogen and it needs to attack it. Let's say you were transfused with blood that contained the rhesus antigen, and your body didn't have the rhesus antigen, then your B cells of your immune system would recognize that this is something that doesn't belong to your body, and it would launch an immune response and create something called antibodies against that rhesus antigen. And we call these anti-D antibodies. So why is this important in pregnancy? Well, if the mum is rhesus positive, we've got nothing to worry about, because that baby can be rhesus negative or rhesus positive, and she's never going to try and attack that baby's blood cells. But if that mum is rhesus negative, meaning that she doesn't have the antigen on her red blood cells, and the baby is rhesus positive, meaning that he or she does have the rhesus antigen on their red blood cells, it means that any time that baby's blood gets into the mother's bloodstream, she's going to create the anti-rhesus antibodies. So how does the baby's blood get into the mother's bloodstream? This can happen at any what we call sensitizing events. So this could be a miscarriage after 12 weeks, abdominal trauma where there's been some bleeding inside the placenta and some blood cells have got across, or it could be at birth when there's obviously lots of bleeding and lots of mixing of mum and baby's blood. Usually this doesn't have much of an impact at the time because the mum will just destroy the blood cells that have got into her system. But in future pregnancies, what happens is those antibodies that the mum has developed will be able to cross the placental barrier because they're only very small proteins, and they'll get into the bloodstream of the baby and start attacking the baby's blood cells. As the baby's blood cells are hemolyzed or destroyed, that releases chemicals into the baby's body, particularly something called bilirubin. And bilirubin is responsible for creating jaundice. A slight jaundice in babies is normal, that's called a physiological jaundice. When the bilirubin level gets very high, it can cause significant brain damage and actually long-term learning difficulties and disabilities. This process of antibodies crossing across the placenta into the baby's bloodstream and causing a hemolytic anemia and a severe jaundice is called hemolytic disease of the newborn, or HDN. So the question is, how do we prevent this situation of the mum becoming sensitized? Well, we use something called anti-D immunoglobulins. And what these are is basically the anti-D antibodies, and we give them by an intramuscular injection at any event where the mum might become sensitized. So anytime the baby's blood might have got into the mum's bloodstream. And what this injection does is it circulates around the blood and destroys any of the baby's blood or any of the blood cells in the mum that contain this rhesus antigen. And by destroying all of the baby's blood cells before the mum has an opportunity to launch an immune response, you prevent the mum becoming sensitized and developing her own antibodies against the rhesus antigen. So what we do is, in every new mum, every pregnant lady, we check their rhesus status. And if they're rhesus positive, we don't have to worry about rhesus incompatibility at all. She won't have any problems related to her rhesus group. But if the mum is rhesus negative, we have to assume that the baby is rhesus positive. And so what we do is we give her an anti-D immunoglobulin intramuscular injection anytime she might be sensitized to the baby's blood. So this would be things like late miscarriages after 12 weeks, abdominal trauma, or any bleeding during the pregnancy. We also give anti-D injections to mums at 28 weeks of gestation, and then we check at birth the baby's blood group by taking a sample of the baby's blood from its umbilical cord, and we give the mums an anti-D injection if it turns out the babies are rhesus positive. If the babies at birth are rhesus negative, mums don't need an injection.
I hope you learned something about Rh incompatibility with the video I inserted in our lecture. However, let me also try my best to simplify or explain the Rh incompatibility condition in the manner that I could. Now, sa Rh incompatibility kasi, theoretically, there is no direct connection between the fetal blood and the maternal blood. Okay? So, basically, there is no mixing of the blood cells from the mother and the baby. Kasi nga, there is no connection between the two. So, what circulates in the body of the fetus circulates there, and then what circulates in the body of the mother only goes there. Hindi po sila nagmimix. However, in conditions with Rh incompatibility, there are conditions that should be met before this disease can occur. Yung isa is that the fetus should be Rh positive. As you can see in the symbols here, the fetus is Rh positive or they have the D antigen. Now, in the mother should also be Rh negative, or the mother should not have the D antigen. So those are the basic conditions or parameters for Rh incompatibility to occur. In some conditions po, there are occasional placental villi breaks. Ang nangyayari is that there is a slight separation of the placenta from the uterus, and that will now lead to an opening or an entry point for the blood of the mother and the baby to mix. So what happens is that when there is a small placental villi break, it leads to the entry of the blood of the fetus to the mother's circulation. So because of that entry point or passageway, dahil nga sa merong gap dito na nag-separate ang ating placenta at yung uterus, what happens is nakakapasok yung konting dugo ng fetus sa circulation ng mother. You have to remember that the fetus, the blood of the fetus is Rh positive, and the blood of the mother is Rh negative. Okay, wala silang D antigen, dito naman may D antigen. Now, when there is an introduction of the positive Rh blood of the fetus to the negative Rh blood of the mother, ang mangyayari is that there is sensitization. The mother's body will say, there is a foreign body in our circulatory system. This D antigen is not part of us. Therefore, we must kill it. So what will the body of the mother do? Dahil nga sa D antigen negative siya, magka-create siya ngayon ng antibody. D antigen antibody, which will kill the D antigen. Okay? So si negative D antigen, mag-create siya ng antibody which will kill the positive D antigen. Alright? So that is what we call desensitization. Now, in this way, konti lang po yung nagfo-form na antibodies. So basically, kung may konting break man yan, may konting antibody man na na-form, it is not that fatal. But, you have to remember na ang nangyayari na ganito, yung massive production of antibody, is after the delivery of the baby and the placenta. Now, during the placental delivery, kunwari, pinanganak na yung baby, and then we will have to deliver now the placenta, there is already an active exchange of fetal maternal blood due to the loosened placental villi. Ang nangyayari is that since nag-separate na po yung placenta and yung uterus, malaki po yung opening dito. Okay, there is a break in the integrity of the uterus. So what happens? There is active exchange of blood from the mother and the baby. So nakakapasok yung maraming dugo ng bata sa circulation ng nanay. And what will happen? Again, sensitization will occur, but this time, there will be a great number of antibody that have been formed because nga there is large amounts of blood introduced in the circulation of the mother. So yung tatatlo na na-form during the placental break na minention ko kanina, mas dadami pa yan ng dadami. So therefore, the mother is now negative D antigen pero positive D antigen antibody. So negative siya sa D antigen pero ang meron si mother ay D antigen antibody. Okay. As mentioned earlier, the mother is still Rh negative but she already has the D antigen antibody. Now, in the second pregnancy, kunwari nabuntis ulit yung nanay and meron na siyang D-antigen antibody. Kunwari, the baby is again Rh positive, but the mother already has the D-antigen antibody. The mother's blood, which contains that D-antigen antibody, will destroy the fetal RBC early in pregnancy. And what will happen? The blood of the mother basically is killing the baby, okay, or the growing fetus. And by the end of pregnancy, the fetus is already severely compromised. Okay? And the baby, after it gets delivered, will appear anemic. Kasi nga po, yung antibody ng nanay is already compromising the blood of the fetus. So, ibig sabihin, the baby will have too much hemolysis that have occurred in their body because of the RBC death caused by the antibody killing the antigen. Okay, so paglabas ng bata, the baby appears anemic and they will have progressive jaundice, thereby causing hyperbilirubinemia. So what do we do if there is Rh incompatibility? Well, there are a few managements that we can do. Number one is intrauterine transfusion. We can also induce labor, or we can also give phenobarbitals. Now, let's zero in on intrauterine transfusion. Paano ba to? In intrauterine transfusion, it is given to combat RBC destruction. We know for a fact that the blood of the mother is destroying the blood of the fetus. So what we can do is that we can inject a donor blood during pregnancy. So what the doctors will do is through guided ultrasound, they will puncture the abdomen of the mother and then passing through the uterus, and then they will puncture the umbilical cord and then they will give the donor blood. It is injected in the umbilical cord to supply or supplement the RBC of the fetus. Alright? So, kasi nga alam natin na konti na lang yung kanyang RBCs because the antibody that is present in the body, in the blood of the mother is destroying or causing hemolysis in the fetus. So, we can, the doctors can decide for intrauterine transfusion. Aside from that, the doctors may also opt for induced labor. Okay? Kasi we know for a fact na pag matagal pa yung fetus inside the uterus, therefore, there will be more hemolysis that occurs. Kasi nga, mas maraming time pa na exposed yung fetus to the destructive antibody that is present on the blood of the mother. So basically, what the doctors will decide is they will induce labor. Bibigyan na yung patient ng betamethasone to hasten the production of surfactant, and when they have decided that the newborn can already survive extrauterинely, they will remove the fetus from the destructive maternal environment through either induced labor using oxytocin or using cesarean section. So, depende na po yun sa doktor. Ang importante po is that we remove the fetus from the destructive maternal environment to prevent further hemolysis and further hyperbilirubinemia. They can also give phenobarbitals. Phenobarbitals are medications that are given to mothers on the last few weeks of pregnancy. And ang ginagawa kasi ng phenobarbital is that it aids in the maturity of the liver of the fetus to help them convert indirect bilirubin to direct bilirubin because it will hasten the production of glucuronil transferase. So alam kasi natin that these patients will have hyperbilirubinemia because of the Rh incompatibility. So what the doctors will do is that they will give these neonates or fetus a head start. Bibigyan na yung nanay ng phenobarbital so that the liver of the neonate will be matured enough to convert the indirect bilirubin to direct bilirubin, which will decrease hyperbilirubinemia through the production of glucuronyltransferase in the liver. Now, another blood incompatibility, aside from the RH incompatibility, is what we call the ABO incompatibility, or basically in layman's term, it's called the blood type incompatibility. Now, for this condition to occur, the fetus must be blood type A, but this can also occur in patients with blood type AB. Now, si fetus dapat type A or type AB, and si mother should be blood type O. Now, what happens kasi in ABO incompatibility, you have to remember is that the mother is blood type O. And pag titignan natin yung chart dito, the mother contains the anti-A and anti-B antigen. So, ibig sabihin meron siyang antibody against the blood types A, AB, and B. Now, what happens is that because the mother contains the antigen, antibody against A, AB, and B. So, ulitin natin ha, si mother, it contains antibodies against these other blood types. What happens is that these antibodies will also destroy the blood of the baby. But typically, it usually happens in patients with type A and type AB. So, yung mismong type O na meron ng naturally antibodies against anti-A and anti-B, it will destroy the blood of the fetus who is type A or type AB. So, parang shortcut lang po siya ng RH incompatibility. No need for sensitization because the antibodies in type blood O against antigen A and AB are naturally occurring. Naturally, since the antibodies are already present in the type blood O of the mother, the antibodies are already there. So when the placenta is loosened, there is maternal fetal blood exchange. So, ibig sabihin, there is a possibility that these antibodies from the type blood O can enter the baby using the placenta. Okay? When the placenta is loosened, nakakapasok po yung antibodies from the blood of the mother towards the baby. So, what will happen? Hemolysis or the destruction of RBC can occur and may last until 2 weeks of age. Okay? And the baby may have progressive jaundice and hyperbilirubinemia if this occurs. Alright, so that is your ABO incompatibility. To explain the condition in full detail, I will also be inserting another video from YouTube which will give us an in-depth review or overview, I should say, of how ABO incompatibility or blood type incompatibility occurs. If you want to review the video, you can take a screenshot of your screen right now so that you can revisit it anytime you want.
HDN is a condition in which red blood cells of a newborn infant or a perinatal fetus are destroyed prematurely, resulting in anemia. HDN occurs when the blood types of the mother and baby are incompatible. A blood type refers to the presence or absence of a certain antigen on the surface of a person's red blood cells. Incompatibility happens when the baby has an antigen that the mother does not have. The mother's immune system interprets the antigen as foreign and produces antibodies to target the cells carrying it for destruction. While in principle HDN may occur with mismatch in any blood group, severe cases most commonly involve D antigen of the Rh system. Specifically, HDN may develop if an Rh negative mother having no D antigen carries an Rh positive fetus with D antigen. The first mismatch pregnancy, however, is usually not at risk. This is because the placenta normally does a good job separating the mother's blood from the fetal blood, preventing the fetal red blood cells from being exposed to the mother's immune system. However, at birth, or if a miscarriage or abortion occurs, the tearing of the placenta exposes fetal blood to the mother, who then responds by producing anti-D antibodies. Because antibody production takes some time, it does not affect the first baby. But if the mother is again pregnant with another Rh-positive fetus, her antibodies, being small enough to cross the placenta, can now cause hemolysis. The first mismatched pregnancy may be at risk if the mother has previously been exposed to the antigen in other ways, such as through blood transfusion or sharing needles, or if the placental barrier is breached because of trauma or medical procedures early in the pregnancy. Anemia can cause heart failure, respiratory distress, and edema. Infants born with HDN also develop jaundice due to the accumulation of bilirubin, a yellow product of hemoglobin breakdown. Because red blood cells are destroyed rapidly and infants are unable to excrete bilirubin effectively, its levels rise quickly within 24 hours of birth. Bilirubin is toxic for brain tissues and may cause irreversible brain damage in a condition known as kernicterus. Other signs of HDN include enlarged liver, spleen, and presence of immature red blood cells, erythroblasts, in the blood. Some of these signs can be detected before birth with ultrasound imaging. HDN that involves D antigen can now be effectively prevented with anti-D antibody. It is given to Rh-negative mothers during and soon after the first mismatched pregnancy. The antibody binds to fetal blood cells that leak into the mother's blood, either destroying them or hiding them from the mother's immune system, thus preempting the mother's immune response. Infants born with HDN are usually treated with intravenous fluid and phototherapy, a procedure in which a certain spectrum of light is used to convert bilirubin to a form that is easier for the infant to excrete. Severe anemia may be treated with blood transfusion, intravenous immunoglobulin G therapy, which works by blocking the destruction of antibody-coated red blood cells, and exchange transfusion, where the baby's blood is essentially replaced with Rh-negative donor blood. This procedure is very effective at removing bilirubin and reducing the destructive effect of the mother's antibody, but may have adverse effects.
Now, what are our diagnostic procedures for us to determine if there is above incompatibility? Basically, we can do indirect Coombs test and the positive direct Coombs test. In the indirect Coombs test, this is done to the mothers during pregnancy, and this can help predict the rising anti-Rh titer or the rising levels of antibodies. So basically, tinitignan natin dito in the direct Coombs test if the mother is already creating antibodies against the baby. So that is indirect Coombs test. It's done to the mother to determine if there is an increase in antibodies in the blood of the mother. We also have the positive direct Coombs test. This is done to the fetus to detect antibodies on fetal erythrocytes. So dito naman sa positive direct Coombs test natin, ginagawa natin ito sa ating mga patients or sa fetus, and we are detecting if there are antibodies that have already entered their system. Now, a normal result for Coombs test is called a negative result, meaning there is no clumping of cells, there is no hemolysis, and you have no antibodies to the red blood cells. However, an abnormal positive direct Coombs test may mean that there is already a formation of antibody against the red blood cells of the fetus. For us to get a better vantage point of how the direct and indirect Coombs test is done, I will be inserting a video which is a YouTube link on an explanation of how indirect and direct Coombs test vary or are similar with one another.
Let's talk about the Coombs test. The Coombs test is done to check whether there is an autoimmune component to our anemia. We see this fairly frequently, where patients are having antibodies in babies that might be mom's antibodies that have crossed the placenta and attacked our child's red blood cells, Or in older children, they may just have autoimmune hemolytic anemia. So the Coombs test tells us if there are antibodies, and if there are, what those antibodies are attacking. If there are antibodies is the direct Coombs, and what those antibodies are attacking is the indirect Coombs. These are confusing, and I want to go through these tests individually because it often shows up on your exam. So the direct Coombs checks for antibodies that are actually attached to the blood cell right now, and the indirect takes the antibodies out of the patient, leaves their own red cells in the dish, and then we look at those antibodies and see what are they attacking. Okay, here are a patient's red blood cells. This patient is having an autoimmune hemolytic anemia. Antibodies are sticking to this patient's cells. And these antibodies are sticking to a variety of proteins on those cells. Now, this patient is going to have cross-linking of those red blood cells and those complexes. So these red blood cells will naturally clump together. So when I do a Coombs test, if the blood clumps like that, I can say, yeah, I think there's antibodies. Now, if I suspect there's antibodies, I'll do the indirect Coombs. Here's a red blood cell in a patient with an autoimmune hemolytic anemia. And this patient has both A and B proteins on their blood. They're type AB. Okay? And what the heck, let's make them AB positive. So they have an RH, which is the positive thing on there, and they have A proteins, and they have B proteins, and these are all in the surface of that red blood cell. So this is an AB positive individual. This is sad because this patient is now going to get an autoimmune hemolytic anemia, where antibodies directed at the RH factor are sticking, antibodies against the A protein are sticking, and antibodies against the B protein are sticking. This is a bad scene for this patient. What we're going to do with this blood now, however, is we're going to take all of their blood and we're going to separate out the red blood cells, leaving only the antibodies that are floating in the patient's serum. So now we have just the patient's serum. We're going to take their serum and we're going to isolate it, and we're going to now put it against a certain number of pre-donated cells. So person number 1 happens to have A positive blood. And guess what will happen? All those A antibodies are going to go up and bind to that volunteer's blood. Now we'll put in some B cells, and the Bs will go and attack to the blood. In fact, whatever the protein, it will attack to the blood. Now here's a donator with another protein, X. I don't know what X is, you can make it up. But the point is this patient does not have any anti-X antibodies, so nothing is going to stick to that X. So then what I do is I take these donors' blood and I put it in a dish. Here's the dish. And I've got the first donor on the top left is an AB positive person, the next one's an O positive person, the next one's AB, the next one's B, etc. They also have other things, other proteins like that X1, and so every single pattern there is represented. Every protein by these donors is represented. Now I take our patient with autoimmune hemolytic anemia and I put it in there. Let's say that this patient had anti-A antibodies. All of these dishes would see clumping, but the other dishes would not. So when I look at this array and I see this pattern, I can say, yup, this patient has anti-A antibodies in their serum. I've essentially figured out what this person is attacking. Why am I focusing on this? Why is it so important? Well, if this patient needs to be transfused because their blood is getting so low, and this is their pattern, I know I can't put in A blood. But if this were their pattern, I probably would be okay to put in B blood. Because look, the A's are all bound and the B's aren't. That's how we determine what blood is safe to be transfused into these individuals.
So how do these patients with ABO incompatibility and RH incompatibility look like or appear Basically, for our patients with blood incompatibility, they appear generally pale, and they may also have enlarged liver and spleen, which compensates to the destruction of the RBC. Alam kasi natin po that the liver and spleen are responsible for RBC production. So what happens? Dahil nga sa nagsisira yung RBC ng bata because of the presence of antibodies from the mother killing the RBC of the fetus, ang ginagawa ng liver and spleen natin is that they are working overtime to supply the demand. Kasi nga, konti na lang yung RBC kasi marami ang namamatay. So, the liver and spleen will work overtime to produce more RBC just to compensate for the hemolysis. So, as you can see here, nagkakaroon po ng enlargement in the liver and spleen to compensate for the destruction. Aside from that, our patients with ABO incompatibility and RH incompatibility may also have hydrops fetalis in appearance. So meaning hydrops, meron siyang severe edema, and then fetalis meaning it's in its lethal state. Okay? Now, there is also, like I said, severe edema which can cause heart failure, because the heart will pump fast to push the diluted blood. Okay? So aside from that, there will also be progressive jaundice, as I said a while ago, because typically when there is hemolysis, there will be production of indirect bilirubin, at pag yung mga indirect bilirubin natin dumami ng dumami, it will lead to rising indirect bilirubin level, or what we call hyperbilirubinemia. Now, it can cause kernicterus. So, you have to guard your patients against increasing levels of indirect bilirubin, because once the indirect bilirubin permeates the lungs, it will lead to irreversible brain damage. So, yun po yung mga nagiging problems natin for patients with ABO and RH incompatibility. Now, what can we do for patients with ABO incompatibility? So, alam natin na marami pong RBC death or hemolysis because of the presence of antibodies of the type O mixing to the blood of the fetus with the positive antigen. Okay? So, dahil marami pong hemolysis, alam natin na maraming RBC destruction na nagaganap. Therefore, there will be elevated bilirubin levels. So, what can we do? The best therapeutic management that the doctors will say is that we will prevent hyperbilirubinemia. And how do we do that? Number one is early breastfeeding. Padedehin po natin yung patient natin to speed up the defecation process. Gusto natin na ma-excrete ng patient natin yung excess bilirubin and to promote reabsorption of bilirubin. That's the reason why we want them to breastfeed immediately, para po maiihi at maitain ng pasyente yung mga bilirubin na sobra. Aside from that, we can also expose the patient in phototherapy or Billy light therapy, because these can help in the maturation of the liver enzymes. So what we do is we expose the patient in early morning sun or late afternoon sunsets, because this will help in the activation or maturation of the liver enzymes, which we call glucuronyl transferase. So yun po yung isa sa mga gagawin natin. We subject the patient in phototherapy or Billy light therapy. Yung Billy light therapy po, it usually appears violet. Kaya nga ultraviolet yung tawag sa light na yon. Okay? So before subjecting the patient in phototherapy, you have to remember to always check for the doctor's order. Okay? I-check natin kung sinong pasyente ang mangangailangan ng Billy light therapy, kung ano yung duration ng kanyang Billy light therapy. So that's how we avoid mistakes in our clinical duties. Aside from that, we also have to make sure that we cover the eyes and the genitalia of the newborn with gauze to prevent organ damage. So gagamitan natin siya ng Batman suit. Ilalagay natin yung cover ng eyes and the genitalia, because exposure of these directly to UV can lead to organ damage. So, ipaprevent natin yan by covering the eyes and the genitalia of the newborn. Aside from that, we have to turn the patient from side to side every 2 hours. Bakit natin i-turn yung patient from side to side? So, aside from the fact that we're preventing first degree burn, kasi nga po nakaka-burn din po yun if we expose the patient in extended duration. Aside from that, we want more surface area of the body to be covered with the UV ray. So the more na na-expose natin yung large amounts of skin of our patient, the more that we are stimulating the maturation of the liver enzymes. Therefore, magpuproduce ng mas marami glucuronil transferase ang ating pasyente, which will convert indirect bilirubin to direct bilirubin to promote excretion of this. Kasi nga water-soluble po yung ating direct bilirubin, which will be mixed with the urine of the patient or the feces of the patient. Okay? So, aside from that, we also have to remember to feed the baby before and after Billy Light therapy to prevent dehydration. Kasi nga, we will be exposing our patients to extended periods of time. Medyo mainit po yung ating Billy Light. And if we don't feed the patient before and after Billy Light therapy, ang mangyayari is that there may be dehydration. So, yun po yung isa sa mga responsibilities natin as future health providers for these patients. Aside from that, the doctor can also opt for exchange transfusion, and this is done in severe cases of jaundice, specifically for patients with abo incompatibility na sobrang daming bilirubin level na hindi po kakayanin ng early breastfeeding and phototherapy. So the doctors will opt for exchange transfusion. So, ang mangyayari po in your exchange transfusion is that all blood is drained out of the baby using the umbilical vessels, and then a donor blood will also be introduced or transfused using the umbilical vein. So, gagamitin po natin na access point yung umbilical blood vessels ng pasyente. Specifically, we will use the umbilical vein to give the donor blood, and then while doing so, tatanggalin din natin yung waste blood na full of bilirubin using the umbilical arteries. Kaya po siya tinatawag na exchange transfusion. And that concludes our lecture on Meconium Aspiration Syndrome, blood incompatibility, RH and abo incompatibility, and hyperbilirubinemia. I hope you enjoyed our lesson for today, and you have to prepare yourselves for another quiz on our Google Classroom and Edmodo Classroom, and the attendance for today will be checked using this method. So you have to take a picture of your pet. And then, if you don't have any pet, take a screenshot of an animal that you wish to become your pet in the future. And then you have to upload it on our Facebook group chat with the caption, "Hello everyone, this is Lord or Lady," and then give the name of your pet, of house, give the name of your street, and then a blank of their name, your ordinal position of the family, and then the blank, or you have to say the profession you aspire, of the kingdom blank of your favorite food. I'll give you an example for things to be clearer. Again, if you don't follow the instructions, your attendance will not be checked. So example, this is Soju, my favorite pet. "Hello everyone, this is Lord Soju of the house Maharlika, second of his name, the plain house band of the kingdom of oatmeal shake with banana." So that is how I'm going to check your attendance.